going to talk about Pilon fractures. Our moderator will be Jaimo Ahn. So Jaimo, take over.
All right. Thank you, everybody. Well, while we are pulling those slides up, because I did want to get all of you thinking about how you would treat different types of fractures, and we'll get to those as soon as we're able to pull them up. We do have a great panel today, and I think we're going to have some great discussions. Pilon fractures are not all that common, but when we do get them, they can be quite challenging. And you'll see a lot of whole variety of different ways people approach this. This is not something that's easily templated. You will find going through these cases with our panel that there are very different ways of thinking about this and fixing it, many of which can give really great results, or hopefully great results, for our patients. So once we have these slides up, and we can go through those when they're up, we're going to go through some very basics just to make sure that everyone is on the same page in terms of Pilon fractures, again, because they're not very common. And I will take you through that presentation. And then Dr. Abhishek Ganta, this is a collaboration between University of Michigan and NYU. Dr. Ganta from NYU will be taking us through a complex case, but a standard case where you systematically approach it and you obtain fixation and a good result. After that, we'll go a little bit on the fringe, and Dr. Meelan Patel will tell us about extreme laneling in the setting of a Pilon fracture. And after that, Dr. Sanjit Konda will be telling us about when things are so crushed, when fusion might be necessary. And finally, time permitting, we will get to a case where I will present to you one in which it was really not salvageable, and essentially you have to throw the Pilon away. And as we get into some of the specifics, I did want you to think about the cases that you may have had in the past, as well as some of the challenges that you've had, and start considering what you would do for this kind of fracture, understanding this is just our let's get your brain juices flowing, and we're not giving you CT scans now, but what do you think you would do for this? What are the challenges? What are some of the considerations? And then how about for this case? And these are the cases that we're going to be going through today to understand some of our options for evaluation and fixation. And what would you do for this case? Getting more and more challenging, perhaps. And then finally, what would you do for this case that comes to you hardware out, some of the hardware out, infected, draining wound from a Pilon that was nailed? Okay, so as you consider those, we are keep thinking about how you think you might evaluate and treat some of these patients. And we're going to, after going through these cases, we're going to go to some very basics as well. So our first presenter, or the first case that will be presented, will be a standard Pilon fracture going through the evaluation and steps for successful fixation. Next will be Dr. Patel, who will tell us how we might be able to utilize a nail to help us in the treatment of our Pilon fractures. Third case will be when the joint is so damaged that you may have to consider a primary fusion by Dr. Konda. And time permitting, we will also have a brief discussion on what you can do when you can't save the plafond. What are some of our options? So now going to the very basics. So think of what you would do for this fracture. This patient comes into your trauma bay, and what would you do? And we're going to go over just 10 things, very basic things that many of you probably already know, but just as a refresher. Some of this may be a little bit entertaining. For instance, the definition. What is the definition of Pilon? Is it a bonus payment, pestle, Cuban musical form, or a loaf of sugar? And some of you may already know this if you've looked this up in the past, but actually all of those are definitions for Pilon when you do a web search. But in this case, we're thinking of it as a pestle, like a mortar and pestle, where one a bone gets crushed into another. And for a bonus, if anyone knows what a plafond is, or a plafond, that is the ceiling. And so when you think of in an upright position, you have the talus, which might be functioning as a pestle onto the mortar of the plafond, or the roof or ceiling of the ankle joint. For some very basic epidemiology, we're looking at a peak of these injuries in the 30s to 40s. So they tend to be a younger population, although demographics and epidemiology is always shifting. And so you might see older patients with these injuries these days as well. Less than 10% of lower extremity fractures, not very common, but they can be very challenging because of the constraints that you have on accessing the joint and being able to manipulate the pieces. And they typically come from an axial load, unlike ankle fractures. Even though it affects the ankle joint, ankle fractures are more rotational, and Pilon is going to be more axial. And many of you might see some hybrids where they behave in some ways like an ankle fracture, in other ways like a Pilon. The pattern is important. There's a very basic pattern, even though variations are very, very common. These are the pieces that we're looking for, which we'll show in a minute. The posterolateral fragment, the anterolateral fragment, and then the medial fragment as well. Classifications we're not really going to get into now, a little bit beyond the scope. There are a number, but for this, we're going to focus on identifying these fragments and what you would do in their treatment. So in the evaluation, standard radiographs are very common, and CT scans are also almost always obtained. Now, whether you obtain them before any treatment, after initial treatment, but before definitive fixation can certainly be discussed. But one of the reasons I put the fixation x-rays there as well is because your evaluation helps determine where the actual fixation is going to go. For instance, if you have that anterolateral fragment, then perhaps if you need to control that anterolateral plating, controlling the medial fragment, you can consider placing hardware medially, and as well as if you had a comminution posteriorly, then your fixation might come from the back. These are not one-to-one correlations, but your understanding of these pieces helps you plan for the types of fixation that you might want in the future. The question, this also brings up the question of when to get that CT scan. Some people want it before so they know what they need to do when they first go in, but many of us will get will place the patient in an external fixator if that is needed, which is another point of debate, and then get a CT, get the CT, and then perform plate fixation if needed, although that is also debatable too. So in this case, the initial fixation was getting the length alignment rotation and provisional plating on that fibula, followed by a CT scan, which then brings up some of the goals of initial treatment, which include obtaining that length alignment rotation, especially the length, because if the patient needs to be in an external fixator for a period of time, then not having that length could be problematic. I think it's also really important to consider who's up next and not to sabotage that next person. And the reason I bring that up is because your choice of incision, which we'll see in a couple slides, really affects how the definitive treatment is rendered. So if you go in for length alignment rotation and you provide, let's say, fixation on the fibula, that could very much affect what the next stage is. So if you've already planned and you're doing the definitive fixation, doing more initially would make sense. But if you're not doing the definitive fixation, then perhaps not making a surgical incision could be beneficial for the next provider. Timing is something that's also evolved over time. We used to fix many of these urgently. This came out of, in many cases, an AO tradition of lower energy injuries that were fixed initially. And then we realized through the work of Sirkin and others that with higher energy injuries, that staged would provide better outcomes for patients. But emerging evidence, for instance, from the group at UBC and just recently in JOT, a paper for a tibial plateau and a paper for Pilon fractures suggests that if you select the right patient, then definitive management early has increasing literature support, and I think people are being more selective now. So looking at the approach, I won't go through all of these, but just to say that you can go all the way from a anteromedial, going to an anterolateral, more lateral, posterolateral, posteromedial, and coming all the way direct medial. You can go full circle, as well as a more recently described far lateral approach. In almost any of these intervals, you can safely get to where you need to get to, and that's where preoperative planning becomes very important. Definitive treatments are many, including ORIF, external fixator, arthrodesis. You'll also hear about nailing, and in a unsalvageable situation, amputation as well. A lot of outcome papers, and I like this one, even though it's a little older, because it's easy to remember. In approximately 3 years, a third of those patients are stiff, a quarter still have swelling, and what you see on radiograph doesn't always match the clinical. So there are patients who have a great looking joint but may still have ankle pain, and others who may have an ugly looking x-ray and you might not feel the best about it, but might still have reasonable outcomes with some stiffness and swelling, but are still quite functional. And with that, let's actually go for this, so that we can save some time, go to Dr. Ganta's talk if we can.
So we're going to go over kind of a standard Pilon, and anytime I think about Pilon fixations, especially like a more standard approach, we want to think back to the classic principles of Rudy and Allgauer. So anatomic reduction and alignment of the fibular fracture, and although this is somewhat controversial now, keep in consideration whenever you're looking at any sort of standard injury. Restoration of the tibial plafond, so getting an anatomic reduction, if possible, of the tibial plafond. And then what ends up happening is that, once you get the joint surface disimpacted, you're going to have a metaphyseal defect. And so at this stage, we have a variety of different methods and techniques that we can use to address the metaphyseal defect. And then, now lock plate technology, while this may not be as important, addressing the medial buttress, right? So what can end up happening a lot of these fractures, even depending on the mode of failure, is varus collapse. And so, consideration for something put along the medial aspect of the tibial plafond to prevent varus collapse. So, whenever you see any sort of these injuries, you want to think about the direction of the deformity. And this is a mode of failure, essentially. So, starting from the left, going to the right. So you have varus, valgus, anterior, and posterior. And a simple way to think about it is, what can we use to prevent this mode of failure, right? So, if these are going to end up going into non-union or malunion, what they're going to end up looking like is essentially like the injury film, right? So we want to be able to counteract whatever the mode of failure is based on the injury pattern. Okay, so let's go to a case. So this is a 58-year-old female, pedestrian struck, isolated injury. She comes into emergency room, significant blistering and swelling. You can see convoluted tibia Pilon fracture, intra-articular extension, and then you can see there's a large metaphyseal component to this injury as well, and a comminuted high fibular fracture. So, so go back to the mode of failure like we talked about, right? So this is a valgus mode of failure. So how do we want to approach this type of injuries from just a fixation standpoint? So simply put, you want to try to get the push everything over medially. So you want to have something to counteract the valgus mode of failure, right? So this patient goes to the operating room, gets put in an X-fix, and once the X-fix puts on, she gets a CT scan. So based on just this injury, we'll go back to the X-fix. Length alignment rotations overall more or less obtained. And then we're going to talk about possibly going to fixing this, right? So we want to go back to the principles that we've mentioned before. So we're going to talk about reduction of the fibular fracture, or restoration of length, essentially, restoration of the tibial plafond, address the defect, and consideration of something medially to prevent varus collapse, even if this is a valgus mode of failure. Okay, so here's just a couple of cuts through the CT scan. I'm going to pause at the different areas where I think it's going to be important to take a look at the injury pattern. So here's the axial cut. And then we can stop right here. So just like Dr. Ahn showed in the his previous talk on just the basic introductions to Pilon fractures, you have the classic joint involvement here. So you have a large Vulcan fragment. You have a large medial malleolar fragment. You have central impaction, which may not be so easy to tell on this axial view, but there's definitely some involvement there, and a large Chaput fragment as well. And we have some comminution along in the anterior aspect of the plafond as well. The sagittal cuts. And you can see a lot of the joint or the metaphyseal components kicked out anteriorly. And, you're not going to be able to address this technically with just placement of an external fixation, but at least we were able to get the soft tissues kind of back out to length. I'll go through a couple more cuts, and I'll pause right here so give us a better understanding of what's going on. And we can pull up the coronal cuts as well. Okay, so when I see this injury, I want to think about, the CT scan is really helpful to understand and assess exactly the amount of articular impaction and damage that's gone on. So for me, I'm using these cuts to kind of help me figure out my approach as well as my strategy for fixation. All right, so the two cuts that I think that are the most important, I went ahead and put on this slide right here. The axial cut in particular is really important to kind of figure out how am I going to access the different aspects of the ankle joint. There are one or two or maybe even more approaches, right? But we have to be a little bit cautious and be a little bit careful on, making sure our skin bridges are respected in the meanwhile. And the sagittal in particular is really important here. And when I'm going to go over, you can maybe appreciate a lot of the combination, especially in the posterior malleolus here. And I'm going to go over that in a little bit just to kind of show exactly what I'm looking at. So I'm looking at my choice of approach, basically how can I book this fracture open and get to where I want to be. And two, is there any difficult aspects of this injury that I might not be able to do with a standard approach or multiple approaches, and what I have to look out for? So let's just go over determining surgical work. By the way, do I have to push the audience or can I just leave as is? Can anyone see my slides? All right. Good. There we go. Sorry. Go back. So here we are. Going back to the same things I was talking about earlier. So the axial cut and the sagittal cut, I think are the two most important, especially with this injury pattern. So determining surgical approach. So I want to be able to go and access as much as I can through one or two approaches if possible, right? And so for this, if you're looking at basically where all the impactions where I can develop a window working through the fracture, to me, this was more of an extensile anteromedial approach. So for this one, I basically had to use an extensile anteromedial approach, and that's when I use the axial cut. I can look at basically where I can book open the fracture really well. All right. And then here on the sagittal view. So one thing you can see here, a lot of times you want to be able to build everything back to the posterior malleolus. But one thing that was a difficult thing to notice here is that the posterior malleolus did not look so simple for this one. Looked like there was a lot of comminution, and in particular, this injury itself, there's impaction on the posterior malleolus. So, if you're going to go through the back and fix the posterior malleolus, which is typically what's done for these Pilon fractures, you'd be able to buttress the posterior malleolus, bring the rest of the front to the back. It's usually a very powerful strategy to be able to restore not only the anatomic axis of the tibia, but also the joint surface. But here, if you look really closely, the posterior malleolus is impacted, right? So if you were to put screws in, right, and buttress this posterior malleolus, you're not going to be able to disimpact that posterior aspect. And what ends up happening is that you're going to build the joint back to something that's mal-reduced. So for this, decided everything that I would be able to do, hopefully through just an anterior approach. So we started off with first femoral distractor, one pin in the talus, one in the tibia, and we placed this on the lateral side. And hopefully the goal of this was to kind of get it out of valgus a little bit. So even if you do that, you can still get a little bit of translation that you can see here, but at least you'll be able to at least visualize the joint and kind of help decrease the angulation to some degree. We started from the back and kind of worked back towards the front. I had to book the fracture open, disimpact the posterior malleolus, get a clamp along the back, as well as some bumps and things like that you can use to kind of help decrease that posterior translation of the tibial plafond relative to the shaft, and pinned everything in place and then work towards the front. And you can see a relatively large metaphyseal defect. Another thing you want to note is that the fibula, even though we didn't address it in this injury, is pretty much out to length and it's a pretty high fibular fracture. So given the amount of comminution, the fact that we're able to get it out to length, we tried to treat that in close fashion. So we're able to put anterolateral plate and a direct medial plate to kind of buttress this fragment. For some reason, I decided to use more of a thicker stator plate for this patient. I was really worried about the amount of translation she would have had. And I was able to do this all through an extensile antemedial approach and then fill the defect back with, tricalcium phosphate. And at a year out, the patient's healed. She's doing relatively well. She's back to work. And so, one of the take-home points for this is, really understanding the injury pattern, looking at small and fine, minute details as like posterior malleolar impaction, and figuring out where you want to make your incisions, for some of these injuries. And, for this patient, once we stressed the ankle, or fibula was stable, and she ended up healing that without any sort of internal fixation. Thank you.
Thank you very much. Next, we're going to go on to extreme nailing of Pilon fractures. And also for the participants, if you have questions that we can discuss, please put them into the Q&A section. I've basically reset them from the last session, so we can take a look at those in a few minutes.
All right, so I'm going to present something a little bit different, a case of using a nail to treat a Pilon fracture. So this is a 52-year-old male who injured his left ankle. He was on the train platform and dropped his cell phone and decided to jump down to get his phone, and suffered this injury. Had an obvious open wound with a large medially based wound with exposed bone. Here's his initial injury film showing a kind of a valgus deformed Pilon fracture. So he was taken to the OR the same day for IND and external fixation. One thing to point out on the fluoro shots is if you look at the lateral, the posterior malleolar component is pretty well reduced. And then here's his post-op CT. So pretty typical fracture pattern with the large anterolateral fragment and the minimally displaced medial fragment. I think in this case, what stood out to me is that he really didn't have a whole lot of articular impaction. You can see the middle image on the bottom is really the only place where he had any significant articular impaction. So this is one where I start to think, is there some way to nail this fracture, especially given the extensive metaphyseal comminution? And that's really something that I've started to think about more and more with periarticular fractures. We do it in the distal femur nowadays with nail plate combos, but sometimes with a Pilon or even a plateau fracture, there's some patterns where you have relatively non-impacted articular injury, but a lot of metaphyseal injury. And those are the ones where I start to think about, is there some way I can nail this? So 11 days later, his swelling improved, his traumatic wound was healing well, and it had no blisters. So took him back and basically did what you can see here, which is a rim plate ORIF of the articular component. Booked open that anterolateral fragment just to clean out that little bit of impaction, and I was able to get a good reduction of the articular surface, secured that with the plate. And now you've basically essentially converted this into an extra-articular fracture. So a couple screws for the medial malleolus and a nail. So here he is, 2 weeks post-op. And here he is, 9 months post-op. He's doing very well clinically. He's playing golf. He's ambulating without an assistive device. Very little pain. But I told him that it looks like there's maybe a non-union developing in the metaphyseal component. The articular component, as you can see here in the CT, healed pretty nicely. There was one screw, the most lateral screw in the plate, was kind of just into a syndesmosis. So I decided to take that plate out. And as you can see on the top left, he had a non-union of the metaphyseal component. He did an infection workup, which was negative. And so what we did was take him back, took out the rim plate, did an exchange nail. I decided to fix the fibula at this point, and actually use some of the tissue from the fibula as graft, and supplemented with a biocomposite allograft. And here he is, 6 weeks post-op. You can see the medial component is healing nicely, still lagging a little bit behind on the lateral side. And here he is, 3 months, continuing to heal. A little worried about that lateral gap, but on the mortise view, it looks like it might be filling in. And got him walking recently, and he's doing really well. His wounds are healed. And this was all done through, pretty small anterolateral exposure, kind of avoiding a longer exposure to address the metaphyseal component. That's all I got.
Thank you very much. I've written down a question for you in the Q&A session once we get to that.
Okay.
But next, we are going to have Dr. Konda tell us about when primary fusion might be necessary.
Thanks, Jaimo. All right, let's see if I can. So, Matt, I just need to pull up my slide deck. Thanks, Matt. All right, so I'm going to talk about a case of when it may be indicated to do a primary fusion on a Pilon fracture. Still not a common thing to do, but certainly there are reasonable indications to do this. A lot of words on this slide. This is just to get me reminded about this patient I took care of. It's a 37-year-old male, history of schizophrenia with active schizophrenia, who was brought in by ambulance after jumping from a bridge approximately 30 feet. And this was a suicide attempt. Patient did present with obvious bilateral lower extremity deformities, GCS of 15. On physical examination, he had bilateral open wounds around the ankle joints. Was moving all of his toes and otherwise was neurovascularly intact. He did present with other injuries. I'll just list them right now. He had also lumbar vertebral body fractures and also orbital wall fractures and epidural hematoma. So this is a complex polytrauma patient. Just to give you a brief sense as to what this patient underwent, initially on presentation to the emergency department, he, within 24 hours, underwent an L4 to S1 laminectomy infusion, evacuation of his epidural hematoma, subsequently brought to the operating room over the next 3 weeks to deal with his bilateral lower extremity injuries. And here's his injury presentation films of his left tibia. This is demonstrating a comminuted and displaced Pilon fracture with extensions to distal tibial metaphysis and distal tibial shafts as well. All of the injury is localized to this area. X-rays of the right ankle showed similar finding, more comminution at the plafond, as you can see, with extension into, again, the distal tibia metaphysis and into the distal tibia shafts as well. His initial injury CT scan was performed, and I'll quickly just take you to the pertinent part. You can see here, getting towards the ankle joint on the right side, it's, I can't even begin to describe the number of pieces that are here. This is one of those high energy axial loading mechanisms where the 3 common fragments that we talked about have now exploded into multiple different fragments. Left side was a little bit less comminuted, but still had approximately 5 to 6 intra-articular pieces. This is him after he's just been splinted. So these are short leg splints just to stabilize the fracture. Again, just splints, just showing that it's been stabilized. And again, within about 48 hours, this patient was taken to the operating room. Remember, he had that spine fracture that was precluding him from going to the operating room sooner. So he was taken to the operating room within 48 hours for external fixation and then irrigation and debridement of his open wounds. This is his left side, showing again the length alignment rotation has been restored. This is his right side. And at this point, he was in the hospital at this point, just undergoing care for his other injuries. The psychiatry team had been seeing him, and this is where I'll pause just to talk a little bit about, what the plan of care for this patient was, decided. The indications for primary fusion, in my mind, are complex articular fractures that have low chance of healing, and where the patient also potentially is more of a harm to himself and is not going to be able to tolerate fixation and all of the precautions that we would have when someone undergoes fixations. And sometimes need to protect the patient from itself. The other indication potentially would be a geriatric fracture where there's very, very poor bone quality, and you're concerned about obtaining fixation in the plafond area, and maybe consider a primary fusion in that setting. So here we have the decision was made to start with the left side. The left side was the less severely injured side. And here, through a small incision, what I decided to do was his open wound was laterally. So we did go back through his open wound laterally. I did create an osteotomy of the fibula to able to book that open. I usually will then, I prepared the talus joint by just taking a saw across the top to create flat bleeding bone edge. So taking just a few millimeters of the talar dome off. Whatever articular cartilage is present on the plafond side, I will scrape down. But no attempt was really made here to do big dissections in the setting of an open pilon fracture. And so I, sort of just fuse this in situ, just making an attempt to restore length alignment rotation. This is just a hindfoot fusion nail and getting fixation into the calcaneus and the talus and more proximally into the tibial shaft. And then usually what I'll do in this scenario is then I'll just fix the fibula, because we created just a transverse osteotomy. An axially stable device such as some sort of intramedullary wire or nail would be sufficient to fix the fibula. And I do like to fuse the syndesmosis as well. It provides better bony surface area to achieve some fusion. So just scrape the cartilage along the lateral malleolus on the inner surface. We did wait an additional week to get to the right side. The right side was more complex injured, but a similar pattern and similar technique was performed here. The patient did also have a talar dome fracture, which was fixed at the same setting. But again, hindfoot fusion nail with, again, a lateral fibular osteotomy to expose the plafond surface as well as the talar dome surface. And then using a sagittal saw to just take the top part off of the talar dome to get bleeding bone edges and scraping the articular cartilage from the tibial plafond. And then again, securing the fibula fracture fibula osteotomy with just a wire in this case. And then fusing the syndesmosis as well. So for this patient, he did have on the right side, he did undergo additional procedures for his open wound, which was more along his tibial shaft. So he did end up needing integra and skin grafting down the line. But the initial postoperative management for this patient was a non-weight bearing in bilateral cast. I typically do bilateral casts on anyone I'm trying to fuse. For this patient, 3 months. And you'll see that we did take the cast off after 3 months, but continue to keep him non-weight bearing due to poor compliance issues. Pain control for these patients are typically some sort of what I call lopioid multimodal protocol, which our group has published on, which is some combination of tramadol, Mobic, TownHall, and gabapentin. DVD prophylaxis for this patient was aspirin 81 milligrams BID for 4 weeks. And routine imaging was performed at 6 weeks, 3 months, and then 4 months. Here he is at 6 weeks x-rays. This is his left side, still in the short leg cast. Alignment is maintained. And things look like they're doing well. Usually at the 6 week time point, it will change the cast, just look at the underlying wounds, but put the cast back on. The right side, this is just the x-ray with the cast off, but his cast was placed back on at this point. Again, his wounds had been healing well at this point, and overall alignment had been maintained without any evidence of hardware loosening. At 3 months, the casts were removed. At this point, I did switch the patient to cam boots, but I was still a little bit concerned about his overall healing, so he was continued to be made non-weight bearing. Although the patient had reported that he had already been bearing weight on his casts. I felt comfortable at this point. The patient could shower regularly and tend to his surgical wounds. So 3 months, things do look like they're starting to fuse, and his overall alignment has been maintained. And then finally, at 4 months, this is his most recent follow-up is 4 months. He had already started to walk on this despite recommendations not to, but he'd been walking in the cam boots, using an assistive device at this point. He is using a rolling walker, but does feel like his overall strength is improving. There's some evidence on the left side that maybe there's some subsidence of the nail, as you can see here. It's slightly prominent here on the plantar aspect of the calcaneus. But overall, it appears that his fusion mass is likely consolidated at this point. I don't expect there to be any additional migration. That is to be seen, but I believe he is healed at this on the left side. And on the right side, similarly, I do believe he's healed at this point, and he has consolidated his fusion mass. And that's what I have for you for primary fusion. We can talk more about it a little later.
Thank you very much. We are at 8:49. I'm going to go through my salvage, or when you can't salvage, presentation. So if we can have those slides up, I am going to magically skip through some slides so that we can get onto some questions and discussion as well. This is our patient who came to me. Basically, I will summarize in this next slide. Looking like this, had a Pilon fracture that was combination plate nailed, but developed an infection and came to me after the infection was debrided, or at least attempted debridement, with removal of the plate on the plafond, but was unable to walk, unable to function with the draining wound, and a very difficult, complicated situation. So the options at this point for me were pretty limited. I did get a CT scan just to understand what the articular surface was, confirming that things had to be cut out. And to move things forward a little bit, this is what our first surgery looked like, where essentially I put in an intramedullary antibiotic delivery device, as well as a block after resecting that infected and not healed segment. I got to know this patient very well. We were on a first name basis because we had to have so many discussions about the implications and whether he might be back to function more quickly with an amputation versus a multi-stage treatment. And because he was a captain of a ship, he said he would not, if he can't have the agility of his own leg, even understanding he's going to lose a lot of that agility, he said that an amputation for him would be absolutely the last option, because current prosthetics would make it even the best prosthetics would make it very difficult for him to be seafaring. So after the resection, he underwent an osteotomy with bone transport, and I'm going to magically forward us to this point where he has been docked. His regenerate looks great. And at the end, he was back on his boat, his limb salvaged. And even though the function at his ankle was gone now, essentially this was transported to a fusion, he was very happy that he was able to keep his leg and not need to be in a prosthetic. In contrast, another patient, just over the next few seconds here, a Pilon gone bad, again, infected, draining wound. All the hardware had to come out.
Just want to interrupt you real
patient as
quick.
well.
You want to make sure you're clicking
Yes.
push to audience real quick. We're still seeing that title slide. Do you see the push to audience below the slide there that you're on? There we go.
Can you see that now?
Yeah.
Okay.
Yes.
All right. Well, you got the full narrative. So this was a resection. This was starting at the transport, completion of the transport, and a patient relatively happy. He was able to do everything that he wanted, back to golfing, back being the captain of his ship. In contrast, another disaster patient who needed resection, all hardware out, free flap for the soft tissue defect, clear the infection, bone transport. Unfortunately, in his case, his symptoms were not as great as the other patient, and he struggled and struggled. He really wanted to keep his leg, but because his pain didn't get better, he ended up getting an amputation. And afterwards told me he was really glad that he took the journey, but that getting the amputation was the best thing for him at that point in his life. And then he became very functional in a prosthetic. So I think we've seen the full range of functions here. And so we will go to some discussion with about 6 minutes left. If there are any audience questions that you want to present, I have the Q&A up, and I'm happy for us to address those. I did have an initial question for Dr. Ganta. In terms of your standard Pilon, and actually for all of the panelists, if you want to come on with your cameras as well, immobilization, motion, weight bearing. What's your protocol after you fix a Pilon fracture?
Yeah, so for me, for the majority of them, it's typically, splint for about 2 weeks. Take a look at the wound at 2 weeks, and if everything looks okay, get the stitches out at 2. Sometimes I push it off an extra week, but they get put into a cam boot and get started on motion around 2 weeks. And I don't typically let them start weight bearing until 3 months, especially for the more geriatric patients or the injuries that have a really low articular fragment. So those are the ones I tend to be a little bit more cautious on. If there are fractures with big, large fragments, you can lag really well. You can get big, nice reduction reads, and not much bone loss. I'll let them start weight bearing a little bit earlier, like around 8 weeks or so.
What about timing of when are you exploring the boundaries of, I don't want to make it sound like we're doing experiments, but I am still very cautious about early fixation. If I feel like I could do a perk and the pieces are big enough that I can really use perk incisions and fixation, I will fix them early, but otherwise I still wait. How about all of you?
Yeah, I wait. I think there's only been like a handful, maybe like 2 or 3 that I've done that I've been able to get fixed acutely. And I think it's, you look at the skin at first, it looks fine, but then you start making surgical approaches, you start doing dissections, and that's when a lot of the intraoperative swelling can start setting in. And, by the time that you get the patient to the OR, it's usually, within maybe, 12 to 24 hours, somewhere around there. So some of the swelling has already started setting quite a bit. So for me, I tend to be a little more cautious and place them in an X-fix. And, but it's a very patient
Looks like
dependent.
we lost either of the others doing more and more early fixation.
Jim, I think I'm aligning with you in the sense that I think I'm still very cautious with it. Percutaneous, certainly. If there's a Pilon fracture, I think I can fix mostly percutaneous, and I think I'll do it acutely. And then also, similar to the case I think that Meelan showed, if it's more of an extreme nailing case, which will most likely be small incisions, those I'm tending to tackle a little bit more acutely. But anything that's involving a bigger incision around the ankle, I don't see the harm in just waiting even 5 days, 7 days.
Mm-hmm.
Yeah, same. I'm waiting. I've done a few acutely that the timing just worked out that they came in at 9 a.m. and I went and looked at them and their skin looked really good and I had them in the OR by 10:30. Somehow, if that works out, which it never does, you can do it. But otherwise, I think it's better to wait.
Yeah, I would really like to, if there was a practical way of doing it, of going to UBC, because I know they kind of pioneered this or brought this concept back, and they've shown over many patients that it is doable. So their patient selection criteria must be really great. And I think it's just a hard thing to put in a paper or even verbalize. You have to really go and see it. But of course, I can't hang out there for 6 months to see their series. But I'm really curious because trying to get patients back to function at home and all those kind of things seems great, but I just don't know exactly how to do it. Speaking of nailing, what do you think? What's the limit of what you can nail? I am not. I do some extreme nailing, what you might call extreme nailing, but I'm also not too adventurous. What's your decision-making process, and where do you draw the line?
So, like the case I showed, I think if there's a lot of articular impaction, I don't think you can do it. But if you have a pilon where, you have three nice big pieces that you can lag together and get, solid plate fixation, and then, and still be able to get some fixation with your distal locks in your nail, I think that's the ideal case. But very few pilons come in that flavor. So.
Excellent.
One question
Well,
I had.
Jaimo, go through that
Yes.
one question, and then we will wrap it up.
Yep, I think we have 1 minute. Okay, is there a role for more classic arthrodesis rather than the kind of nailing where we do a hindfoot nailing, almost like people do for Liszt Frank? And this was popular a little while ago and then went away. Do any of you do primary fusion without a nail like you might fuse a Liszt Frank?
A great question, Jim. And I think that it's definitely, there's still a role for that. But for me, it's that's the type of patient where they may have a really bad soft tissue injury associated with the pilon that I need to wait more than 6 weeks. And I'm going in to do a bigger approach to get better alignment. And it has got to be a need for me, I think, to make a big incision around the ankle. And if I'm doing that, then I think it makes sense to then to restore the articular congruity before you do the primary fusion with potentially a plate.
Okay. Well, thank you all so much. It is 9 o'clock. I don't want to take away time from our next group. Sorry about some of the difficulties, but thank you all for hanging in there and for a great session.
Thanks.
Thank you.
Thank you.